apologies for absence. We've got Richard Apps, Helen Ellis, and Colin Law substituting for Helen. Faye and Matt, you're covering Faye, and also apologies for Susie O'Neill. And we'll welcome Jonathan. Do we know when Jonathan's coming? Jonathan McGee.
We joined for that item.
Joined for that item, okay.
Yeah.
Jonathan McCree, who's the CEO of the charity, health charity, will be coming into the meeting for that item. And Colin, I know I said it, but thank you for attending in Helen's absence. And any declarations of interest? No declarations of interest, thank you. So I'll hand over to Debbie to introduce the staff patient story, and welcome Amanda Joseph, who is actually going to sort of put together a video and present. So I'm stealing Debbie's thunder.
Thank you, Chair. So before we play the video today, I would just like to start by saying a huge thank you to you, Amanda, for being here and sharing your story, because it is quite personal. So yeah, a huge thank you to you. The first time that I met Amanda, I was fairly horrified actually to hear her story, because the challenges that you have faced through your life have been excessive, I would say. But you had that sheer determination, and that's what I remember the first time that I met you, your sheer determination to succeed. And that will stay with me. So Amanda's story is a really important story, but it's one story, and we'll hear that for 6 minutes on the video, and then we'll have a chance to talk to Amanda. But I would just like colleagues to remember that this is just one story, and we have a lot of staff, a lot of colleagues in our hospital who have also got their own stories. I'm going to make a fairly bold statement now, which is we have got an issue with racism in our hospital, and I don't say that easily. We've got 367 nurses who are internationally educated. I've met with some of those nurses earlier this week, and they told me that they're afraid to speak. They're afraid to speak out about their experience in our hospital. We've got many more colleagues in our hospital who have a different colour skin, who are born in a different country. But when I spoke to those nurses, it really bothered me that they didn't feel that they could speak up. We have 33% of people in our hospital who work here, who have worked here either for many years or for short periods, who are from Black or minority ethnic background. 33%. I just urge us to look around the board table at this point. So later on today in our agenda, we'll hear from Paula about our plans to tackle racism in our hospital and become a hospital of choice. Somewhere where people will want to work and where they will be happy to work. And I would at this point really urge the board to listen to Amanda's story with the intent to commit to our plan. So we need our colleagues to feel that they're not victimised or discriminated against just because their skin might be a different colour. I'm really struggling with a cold today, so you will have to excuse me. Just because their skin might be a different colour or because they were born in a different country. We all know that a diverse workforce is a good workforce. Everybody brings different things to a team, different things to Team KGH, different perspectives and better decision making. So I hope today, and I am absolutely urging the board, that we will all commit to improving the experience for all of our colleagues in our hospital. I would really urge the board to support the plan that Paula will present later. We do need to make change. We have started to make some change. We have started to make some good inroads. But what we now need to do, we need to move to the next level, and we need to do that at pace. There's a huge amount that we could talk about this morning, but at this point I am going to just hand over, well, firstly to Richard to play the video, and then we will come to Amanda afterwards.
Okay, that's good.
Hello everyone, my name is Amanda Joseph, Clinical Pulse Officer at Kettering General. Most people call me AJ, which I'm fine with. I started at Kettering General in 2019 after moving from London and having all of my career in London from 2003. So I've been a registered nurse for 20 years. And I've been in the NHS for 22 years. I joined KGH as we moved my family from London, and I thought that would have been ideal for my career based on where I was. I found KGH very different to the other hospitals that I've worked in. Most people were pleasant, but not very warm. And then I had issues with colleagues not accepting me for who I am as a Black immigrant, disabled Christian woman. I had so many challenges and adversities to overcome in the last 3 years in terms of culture, disability awareness, being of an ethnic minority, and obviously trying to get services and teams to be cohesive with the trust values around staff that look like me. There were instances where I felt that the challenge was even harder because of who I am and my voice wasn't heard. Oftentimes I felt alone. Oftentimes I felt where the systems in place in this trust weren't applicable to me. There weren't fair decisions, fair choices in what should have been an easy decision for people in authority and management. Oftentimes, the stumbling blocks weren't because of me, but because of the systems in place within the trust. So, for instance, your sickness management reviews and your sickness management policies weren't aligned with the Disability Discrimination Act of 2000. There were times when I've seen staff with less issues than I have supported more. And I think when you find the right people to listen and find the right decision makers to hear what you're saying and to value you as a person and who you are, then it makes the decision easier, even if it's a negative one towards me. Hearing other people's stories and people like me, African, Caribbean, Asian, Indian women, Indian staff, Asian staff, sharing their stories, but they're scared of the discrimination. They're scared of, the way managers perceive them as troublemakers or perceive us to be, oh, here she goes again, or here he goes again. It saddens me because the trust values are there, the guidelines and policies are there, but it's not geared to everyone. There is no equity, there is no fairness. So in the last 6 months of me coming into patient experience, PALS and complaints team, it wasn't the senior management that initially made me feel welcome. It was the team itself. And the team, yes, is predominantly British Caucasian, but I was able to be myself, be my authentic self, be who I am, confident, competent, skilled decision maker as a nurse, as a registered nurse with my experience. They welcomed me, they welcomed my experience, they welcomed my voice, they welcomed my passion, and they welcomed me for who I am. And having a line manager and line managers within the team, for instance, Josie and Lucy, listening and making me feel that I'm heard and making me understand that I'm good at what I do and making me know that I'm good at what I do has brought a different viewpoint of Kettering to me. Previously, there wasn't that holistic management. And when you miss the holistic management, you've removed the human aspect of management. And coming into this team made me feel confident. I know that I'm competent, but now I can feel a bit better. I feel a bit better in terms of coming to work and liking work and enjoying work because I'm respected, because I'm listened to, because I'm supported. It inspires me to do more. It inspires me to be better because I am supported and I am heard. And that has been the experience, and I hope it doesn't change.
I love the end of that video, Amanda, thank you. What a fantastic piece actually for us to listen to. I feel really privileged to be here with you today, actually. Thank you very much for sharing that. We know that our staff, through staff survey, through Pulse, through individual meetings, not everybody feels listened to. And it's our job to change that in this hospital. So should we open up for questions and comments, please?
So just by chance, yesterday I went to PALS and we had a discussion about team and their perception, because your colleagues said, I didn't mean staff, and they just echoed what you just talked about that sense of respect for each other and the importance of that. And I just applaud you for being here and sharing the story, but to say that your team that you're in right now, I think is a fabulous team, and we had a really healthy discussion about what a good team looks like and how we should be treating each other.
Yeah, thank you for the video. It's really interesting to get your perspective. You started this, Debbie, by saying that there is a problem with racism in Kettering. I'm just wondering, and it's a difficult question to answer, how widespread do you feel that might be, and how systemic it might be? And I guess, most importantly, what might we do about it?
So if I come in first and then I'll probably come to Amanda, I think it is widespread. I would be naive, I think any of us would be naive to think that we didn't have racism in our hospital. We've got racism in the country. What can we do about it? We're going to hear later on the agenda about our anti-racism plan. And I think that is we've got a way to go, but it's a start. It's more than what we are doing at the moment. But what we need to do is do that at pace. We must not sit back. We've got to make changes. It's uncomfortable, but it should actually be uncomfortable for us to be having this discussion. What do you think about that?
It's rampant. I think I shared this on my Twitter feed on Wednesday. I went into St. Thomas's Hospital, and I know it's in London, and I know it's very diverse in the sense. And within my experience, I've worked in sort of 6 different hospitals, mostly predominantly in London. I've worked in 3 district generals, including Kettering. And the demographic, it's the same. The services are the same in those district generals. So I'm going to remove the teaching hospitals that I've worked in and make a sort of benchmark comparison.
Yep.
And I was sharing with our colleagues that in, I think, 2015, I did this very same thing at Kingston Hospital. And the board looks like this. And my story is one, but having actively listened to colleagues and asking the board, senior management, middle management, the gatekeepers of policies, guidelines, procedures, principles, values, to be more aware, to be more inclusive. I don't see that happening at Kettering in the next 5 years. I've been here 3 years, and the pandemic has shown that it's not going to change. Your workforce is 1/3 of people of the global ethnic majority. That's a huge number. They are the oil that keeps the machinery working, but they are the disgruntled. There is a disparity. And I see it from both sides of the coin, may I add. I live with an illness called sickle cell disease. It's a predominantly African, Caribbean, Asian, Mediterranean disease condition. And I think I was sharing with Debbie, I am even scared to have any treatment at KGH because, one, of the staff racism and the lack of diversity, the lack of, not just in people, but the diversity in care, and the understanding of cultural needs of patients like myself, Asian patients, Indian, South Asian patients, things like that. So there is that need, and I wouldn't say education because we are in a very internet world. You can Google things, you can YouTube stuff, you can ask questions. And I don't think any person like myself would deny a colleague that doesn't look like us to ask questions, to approach us in a respectful way, in a compassionate way, in a way that we are in this space and we can be in this space. I don't know if I hadn't spoken with Debbie, that I would even be given the space to even come to you. And quite rightly, Debbie, my colleagues have, and I said to Trevor and Richard, do I have immunity? I asked that question because we don't have that immunity. We don't have that grace. What we do have is the perception that we are here to do a job, we're paid to do a job, and that's it. But the holistic way in which we are approached, it's negated, it's non-existent. And I am not scared, as I said, I've never been scared in my life to speak up. And being in Kettering was the first time when I raised issues, I became the person of interest, and not in a good way. Yeah?
Yeah.
So that is one story of many of when you have the ideas, the right what should I say, programs, you have the right vision, you do, but the trickle effects hasn't reached to the point of where are we getting it wrong. You want to hear the voices. You want to hear the voices. But who do we share our voice with? Because had I not approached Debbie, I would have been strangulated in the essence of it. My point is, it is there. But because we are scared, we don't see people like ourselves given the opportunity to be in the echelons of the White House. I call Bleep House the White House. We don't have that sort of compass. And let me just say, I have colleagues that are non-immigrant, quintessentially British, that have had their challenges with the systems and within the systems of Kettering. And don't get me wrong, it's there. But what we are saying is that you have a third of your family, that's this one too, a third of your family, that's of your team, that is having an inequality and not having that space. I would like to help, but is it my responsibility? Maybe not. Is it my dream? Yes.
Sorry,
Just two questions from me. Thank you, Amanda. Absolutely, I've heard some of those reflections and some of the things that I've been involved with, and certainly things like our Levelling Up programme. So we have hugely experienced staff coming to our organisation on Band 5 roles, which is correct, because that's where we need to recruit, and that's what people are applying for. But I do think there's a lot we can do in this space, actually, really outside of Paula's programme, really, which I think is essential. But just thinking about, doing things at pace, there are things we can get on with. So I've made a commitment to, we have a programme called Levelling Up, which are for our internationally educated staff, who, as I say, have huge amounts of experience. And it's a programme to make them confident. And I've made a commitment to giving them things like CV advice. Because I think what we need to do is embrace our staff and give them the same sort of opportunities. So we have to recognise that some of our staff are not great at completing application forms or CVs or describing their experiences elsewhere. And I think actually just reflecting on Amanda's story, and certainly we've had quite a lot of conversations, it was, for me, it was recognising the huge amount of experience that Amanda brings as a nurse, how we use that experience slightly differently, but how we use that experience. Let's not lose Amanda's nursing experience. So how we keep really good, strong, competent nurses within our profession. So that I think is a commitment that we need to make. The other thing I just wanted to say, if I may, Chair, was I don't think there's any, well, I hope there is nobody sat around the boardroom that thinks racism is okay. I don't think there is anybody. But sometimes some colleagues find it difficult to find the right words. Mm-hmm. And I just wondered, Amanda, your reflection on, sometimes I think the active bystander colleagues that may witness things, hear things, see things, but don't speak up. And it's maybe some, just very briefly, what you might suggest to colleagues, as in what are the right words to use.
Amanda, before you answer that, just wait one or two other people want to come in, and maybe Bex just...
Can I just answer James, because I have a kind of memory issue.
Yeah.
So the first issue, James' first comment, I'm not internationally educated nurse. I was trained at the University of Hertfordshire. I came to England 3 weeks before my 18th birthday from Trinidad and Tobago. And I knew no one. Well, I shouldn't say that. My mom's friend, who wasn't the best person, but she was kind enough to have me in. So I'm 44 this year. 44, yes, 44. Do you remember that? And prior to coming to Kettering, I was at the top of Band 7. As a specialist nurse, leading the service, teaching at the University of Kingston, running the service, an anemia service. I was a specialist transfusion nurse. And just recently, last year, in fact, because of the stress of Kettering, I wanted to change jobs, change roles. I can't leave Kettering because of my health and things. I can't commute back to London and stuff. And what happened was, there was the exact role that I was doing as a senior Band 7 in London, with leading and doing what I love to do. And the job came up at a Band 6 role. I applied, and then I wrote a letter to the lead nurse of that service. And I said, I know the job is at the Band 6, this is my experience, and I'm happy to remain as a Band 6 because anyway. And I would like to have an informal visit to the department, and hopefully I can join the team based on my experience, my knowledge, everything. She was very hesitant. We did meet. And the first sentence that lady said to me on meeting was, "You do know that this is a Band 6 role?" And I said, yes. And I said that in my email. And I said that in my application. And I said that on meeting you. And she said, "You do know that there isn't a scope for another Band 7. And I said, "You've illustrated that in your email and you've explained that to me." And I was hoping to get back in to that role and to that field, because that's what I've been doing for 16 years. That's probably all I know, hematology. And it became very antagonistic, the conversation at the informal visit. At that time, there wasn't a shortlisting. They hadn't shortlisted, and I was shocked that I was shortlisted based on that informal visit, based on the conversation. Then I went to that interview half-heartedly, based on the interaction with the leaders. And you're saying about leveling up and everything else. I have been at Band 7, I've been at senior level nurse role from year 3 of qualifying, when it was the old E and F and G grades. So I know the level of position and things like that, but I have resigned myself to back off at Kettering for any role above a Band 6. Why? Because I know I will never get it. That was the second time I have applied for a role in this trust to level up. My first time was, I started in the August of 2019, and the first time I applied for a Band 7 role to be the ward manager of Cranford Ward. And that's when all hell broke loose. I was interviewed, I was offered the job, and based on my ward manager, my current manager at the time, she felt that I was not ready to be a Band 7. She felt, for whatever reason, and made some trumped up charges, and that's all I can say it was, that I failed patients, that I failed the team. And I went through a long investigation, 6 months. Thank God for COVID. I don't think anybody in this room would say thank God for COVID, but that was my insula, my thing, sort of like get out of jail card, basically. COVID. How horrible that was. And it was drawn out, and I think I spoke with Andy Callow, who helps me to understand myself, understand Kettering. And he was the one that sort of intervened with the assistance of Carl Werner and things like that. But make a long story short, I have tried to level up.
Yeah.
I have tried to get there. And many others have tried to get there. To what extent? To what it felt, what should I say? Disrespectful, disloyal, and it was soul destroying. And anyone who has ever walked in those shoes would tell you how soul destroying, because you lose all confidence, you lose all, not just in yourself, but in the people, the system, the decision makers, the ones that you think are clapping for you, but are plotting for you. The ones that saying, you're a goodness, you can come and do a bank shift for us when we're short staffed, but I am not able to run a shift. The ones that are saying, oh, you're a goodness, but you're not ready. How is someone not ready that has worked in an organization for that long, for that amount of time, never ready? And I've heard a colleague say to me, oh, I got a promotion. Guess how I was interviewed? Oh, I was collecting some IV fluids and the head of nursing and the matron said, oh, there's a job going at such and such ward. Would you like to have it? And I took my wig off having that conversation because I was so blown away by how lucky are you? She didn't know my story. She's less qualified than me, less confident than me. She's like, Amanda, can you mentor me? You've been there. She's white. So in terms of the leveling up process, I've tried that process. I did that course, and the last day of my course, which was last year, because the trust was an Opel 4, I had said to my line manager at the time, I will come into work because it was a protected study day. I was office shielding at the time, so I was working in the office. I was non-clinical, non-patient facing, non-clinical. And guess what happened? You can't attend that course. It was a Zoom course. It was the final day of the course, and I did not graduate with my colleagues. I did not have the outcome of putting that on my CV for another job that I really wanted, because that would have helped me. And I'm yet to finish that course. And guess what? And we have to redo the whole 12-week program to get that qualification. Why? Why was that? So in terms of the leveling up, that's your first point. The second point is, would you be comfortable saying the things that you would say to a person of color, a person of global ethnic majority, whether they're European, whether they're African? Would you be happy to say what you are saying in the colloquial context to your indigenous Brit colleague? If the answer is no, then don't say it.
That's a really good point, actually, Amanda, and something that we perhaps need to just hold.
If you're not going to feel comfortable with saying to a female colleague something, don't say it. Yeah?
I think also, if I just reflect just briefly on that last point, be in my bonnet, but I think others would reflect on this. It's not just about saying it face to face, it's what people write as well. And so social media, whether it's on the system. Thank you very much, Amanda. Very powerful, a lot of it in there, and I think you'll welcome the challenge around things like leveling up. That doesn't mean that we shouldn't be doing them, but it's how do we do them? How do we do them with you and your colleagues? As you say, you said yourself your one story, but I think many other of those stories are going on later when we think about what we need to do. We need to be very mindful of the time scales that we're looking at around this. Actually, what can be done tomorrow? one of the important things I think also I'm hearing, and not just hearing, but I think we know what we do about it, we've known for some time, is how do we permeate these things throughout the whole trust? So how do we both provide leadership and challenge to make sure that actually throughout the organisation, people are treating each other in an appropriate way that they would expect to be treated, but that we're also mindful of both ethnicity and cultural backgrounds in having conversations, looking at how we work, and thank you very much again, Andy. Sorry, John.
Could I just say, I'm the chair, I'm very sorry I was late, but my car broke down. But I heard enough to know how dramatic it is here, and you know, you said, what, well, I think it's going to tomorrow. I think tomorrow the board need to formally acknowledge that we've got a real problem. That's the first step. It's not a great first step, but actually we have to do that. And then we have to move on. We'll be talking about this later on, we've got later on the agenda, but it seems to me the first step is for the board to actually say, we've got a real problem here. We recognise this racial and trust. We're going to do something about it, really commit to that, and then acknowledge it. And if we don't acknowledge that, we haven't even got to the start.
Can I just give one insight? That your staff of the general population are actually your service users. Okay? So I want you to think about that as well. Because if your staff are living in this community, they're going to be using these services. And if they're not being treated well, and if they're not being with those values, it cannot be embedded in the care that we give, not only just those patients, but every patient. So not only look at your staff surveys and things, but your patient outcomes, your patient service users, things like that. I just want to say thank you for the opportunity, and I look forward to working with you and to exploring and implementing the changes that you guys decide. Thank you.
Thank you.
I've met most people, but for those I haven't, or for those who are tuning in, I'm John Donald, I'm chair, and I really apologise for being late for my very first meeting. I'm tired from the rest of the on the way back to my house. I'm going to be dropped off here, so I do apologise for that. And thank you, Trevor, for can I also thank Trevor for being the chair for the last really great job, and I'm very grateful. I will be working very closely with him because with 4 chairs around, I can't do it all myself, so I'm really grateful for ongoing support with Trevor. We'll talk about that later. Okay, thank you. We can then move on then to minutes of the previous meeting. So can I ask if there are any comments there on accuracy, first of all? Thank you. Maths arising, Richard. There's 2 on there you want to draw attention to. Is it 2 or 1?
There's 2, I believe. Yeah, the issue around the ICB meeting attendance, which you're working with the ICB chair on.
I work with now, and I'm talking with Trevor and Rachel. I think that we are going to be looking at and there's some new appointments, and I think on the back of that 2 things. One is I do think we should have representation. I know but we also, I think, need some discussion about where's the value added with the ICB. So I think there's 2 agendas there, which I'm talking now, but we'll be talking about the next. Okay.
And for the other actions, they work on the 23-24 plans that we're leading.
Yeah, so there's been lots of work in the background on this in terms of working with accountable executives for each of the strategic priorities. We've also taken a pin to the HMT. It's taking a little bit longer than we would like, but we've got some workshop sessions which we're holding decisions to make sure it's kind of grounded within Kettering as well as the group, but hoping to come back to committees in August.
Okay, any other questions on those? Thank you. Debbie, I think you take us through this, don't you, and coordinate the order and everything else, is that all right?
I don't know whether you've got your
Well,
shared
sorry, I
report
should just say a
first.
few things. First of all, to say I'm really pleased to be here. I mean, I've had a really warm welcome for people. I think there's some real opportunities for us, not obviously within the trust, but I think across the collaboration. And we do need to think about how we can see that, but I think there's some real opportunities there. And I think there has been in the past some real enthusiasm for that, some really good work. And I've seen you work here in my very few visits, some really good things. So I will be visiting more and around. But certainly over the next couple of months, really, I think we need to come to rest with exactly what that collaboration should look like and what we're trying to achieve out of it, and what are the things we're really going to focus on. And so I'll be having discussions on this over the next couple of months. We've already started with we have a joint board. I think that's really helpful. But there's a lot of more work to do. I look forward to working. Thank you.
So if I move on then to my monthly report. So throughout my report, I've made some comments on some of the items that are throughout our agenda today, but there's just 4 things that I would specifically like to pull out. The first one is Children's and Young People Services. So colleagues will be aware that we've had 2 unannounced inspections from the CQC. I'm really pleased to see the changes now which are being introduced, and not just changes that are being introduced, but changes that are now being sustained. It's really making a difference for our young children and their families. On visiting Skylark Ward, which has been one of the main focus of our CQC inspections, it feels like a completely different ward now. The children are playing. You can see them in corridors playing, and our colleagues really want to be there. They're happy to be at work, which is just fantastic. Patient satisfaction and experience has significantly improved, and I can't overstate that actually. It's made a real difference. What's really important now is, Jane will obviously speak about the inspection report on the main agenda, but we mustn't sit back at the moment. We're doing really well, and it would be quite easy for us to just sit back and let things continue, but we need to move to the next level. It's really important that we continue to improve, and not just improve, but also to learn, because mistakes will happen. Human factors do happen, and we have to continue to learn and improve. We will expect the CQC to come back and inspect us again before the end of the calendar year. It will be an unannounced inspection, and I expect that they will look at much more than they have in the first 2 inspections. It will more likely to be a full inspection. I would really hope, and I think Jane and John both share this, that when they come back, they will re-rate us. And I hope that we will be re-rated good at that point. And that's what we're working towards. I would like to take this opportunity actually to thank Jane for her leadership with this. The amount of work that you've put in place across PCD, across Skylark Ward and LNU has been huge actually, and also our colleagues who are working in CYP services. This has been an extremely difficult time for them, as it has for the families. Some of the families that I've spoken about previously that we have let down. It has been a difficult time, but we are improving, and I'm really pleased with the recent CQC inspection report. The next thing I'd like to do is pay tribute to two of our colleagues who have recently lost their lives. So we've lost two colleagues from our KGH family. Andrew, who you will be aware was tragically murdered, along with her two children. The second person is Ralph. Ralph is our gardener and one of the longest serving members of the NHS. He's worked and lived at Kettering for 64 years. He joined in 1959. Quite a few of us around this table, I expect, were not born then. Many colleagues will have known him. It's true to say actually that he dedicated his life to Kettering, and I think that we have to pay tribute to that today. And I'm also pleased to say that during our break today, we will be able to see the funeral cortege passing through our hospital grounds. And I hope that the board will join colleagues in the hospital to line that route. I want to finish with a couple of things that are much more outward looking. So the first one is the East Midlands Acute Providers. This is a network of acute providers in the region. This network has actually been in place for some time, but there has been a recent reset of what we call EMAP, East Midlands Acute Providers. And that reset is looking at some new governance and some new project management arrangements. And that's generally because there's been quite a lot of change across the region at senior level. We already work really closely with both Leicester and Northampton. I think what this now does, it provides us greater opportunity at scale across the whole of the region to make some changes for our services, especially around those services that are fragile, for example, but also for some of the enabling services such as digital. And there will be much more that we can do if we are at scale, we're stronger together in that space. I'll bring more on that as the work progresses, but I will continue to make sure that that's highlighted in my CEO report. And finally, the other area that I just wanted to know, which is not something that I have regularly brought to the board's attention before, is the work that we have started to progress at place level. Polly has also started to get into some of our place level work, which I expect will continue at some pace now. We have got 7 local area partnerships and 4 community wellbeing forums that are now in place. They are only just in place, so this means that we can now start to develop our work programmes. They're going to be mainly focused on wellbeing, on transport, on social isolation, all of which we really do need to get involved in because it will help. It will help with our local population, it will help with the health of the population, and as we know, in the north of the county, we've got areas that are really very, very deprived. We also know that especially through winter, when the dark nights start coming, we do see elderly residents start coming into hospital because they feel isolated, they want some help, they want some support. So we really will start to get into this space around place. And of course the Cardiology Centre of Excellence work, which we as Kettering are leading on, is starting to look at pathways for heart failure, for example, which is right through from the patient's home, right through to tertiary care, through primary and secondary care. So linking all that together and working at place level will be a real opportunity for our local population. I will stop there, Chair, and take any questions.
We'll come back to the CQC report, which will be later on the main agenda, so perhaps any other people on that we can take them.
No, it was children and young people.
Right, yeah. Why don't we take it, are you okay with that, taking that?
Yes.
Debbie, I'm really interested in place-based work, especially with Parkinson's. I think we really do need to think about the personalised plan for people in communities rather than one size fits all. Building on Amanda's experience, do you think we've got a strong enough emphasis at place on inequalities, culture, and kind of not isolated communities, but communities that could just get subsumed in the kind of majority around it. It's really lacking.
No, it's okay. I think I understand what you're saying. So I think we know where we need to do the work, but because the local area partnerships and the community wellbeing forums are just starting to get their programme of work together, I am not yet confident that we are doing what we need to do.
Okay.
But I expect that that will come in time as part of the programme of work. I don't know, Polly, if you wanted to add in.
I would agree with that, and I think we're currently going through the process of doing a draft strategy for our place. So I think we need to take that opportunity to make sure some of those things are absolutely embedded within it.
It was just Amanda said, you know, they live here, they work here. Actually, you don't need to go out to place to find them. That they could give us the experiences of place over lunchtime or as part of their working day. So it's kind of taking advantage of.
I think it's a
their
really
experience.
it's a really good point that Amanda made, and actually Trevor and I were discussing this earlier on in the week around. I was speaking to our imam, Osman. I don't know if colleagues know him, and I was asking, how do we start to get out into the community? And he said exactly the same as what you've just said, please, which is they're here. They're here. We need to really start to talk more to our staff around their health and the population and what they want. And it was quite disappointing. I don't know if you were here at the time, John, when Amanda said that she didn't want to be treated at Kettering, and she's going elsewhere for her healthcare. And that saddens me, actually.
I mean, I think this is a really important point, particularly when the concept of staff is actually right. We know the quality of access. We know the outcomes for different groups, including some services for women, are much poorer. And I think there is an opportunity to further social conversation. And some of that will be in place, but actually there's stuff we can do in this hospital. If you look at just how we encourage people off waiting lists. Some hospitals are starting to look at ethnicity and access and wider comorbidities in prioritizing people in a much more explicit way. So there are some things we can do ourselves, as well as how we work with partners in place. Absolutely.
Thank you.
Your report mentions insourcing at weekends. Could you just say a bit more about it? What does it cover?
Yeah, I might just hand over to Matt actually at this point, but this is all about increasing our access.
Yes, we started 2 weeks ago, and the main focus initially is on oral surgery because that's where our longest patients wait, and then we're focusing over the summer on children's because summer holidays is when they're most available, and that's mainly around the ENT subspecialties. So we've been sourcing this running with our surgeons and a combination of external surgeons and anaesthetists. The first 2 weekends have gone really well. It's a company we've worked with previously and integrated with our teams. And yeah, so it's just trying to maintain and increase our length of recovery, basically, to try and maintain and reduce our wait times.
Thank you. And do they undergo induction, and are their results audited?
Yes, we've got a full governance process behind that. We've done work over the last 2 years, so that process is pretty well embedded in terms of feeding through the social governance route, and yeah, it's a very well established process.
Great, thank you.
This is really, Chris, about making sure that we sweat our assets, which the biggest asset we have.
But it's got to be done safely and from a governance sense.
Great, thank you.
Thank you.
Move on to
IGR?
the
The IGR, thank you. Yeah, is that okay?
Yeah.
Thank you, thanks Chair. So I will come to each committee of the board separately, but I think I hope colleagues can see the huge amount of work actually that's gone into the IGR over the last couple of months. I think we are making some inroads with our integrated governance reports, and especially with regards to the upward reports, it's much clearer. I was reading through our IGR in preparation for the board, and the majority of our metrics are in a good place. Also, on looking at the performance in the region, we are one of the best performers in the region for elective work, for cancer work, but there is more that we can do. There is definitely more, hence the reason why we need to outsource, hence the reason why we need to continue to do some activity whilst we have industrial action, for example. So I will start with Clinical Quality, Safety and Performance Committee, and Chris, please.
Thank you. So I think 5 things I want to mention. First of all, the work of the committee. We have enhanced the subgroup reporting, and that now comes very early in the agenda rather than right at the very end and almost ignored. So subgroup reports are very important. Those are those working groups, the transactional groups, that feed up to this committee, which is an assurance committee. The second thing is we're taking items of urgent business so that we know about challenges and problems as they occur, rather than waiting for formal reports that may come many months later. Third thing is, just wanted to draw your attention that one of the benefits of this committee is that we were able to discuss issues in the oncology service at Northampton that affect patients for the whole of the county, and that there is staff development work going on in that service to improve the situation. We had a report on the breast service collaboration, and there is further work to be done there. And the 5th thing, and I'll leave my specs to read it, is the committee effectiveness review, which we're going to discuss later on. So those are the 5 things I wanted to mention.
Lovely, thank you. John, anything to add?
Sure, yeah, no, thank you, Debbie. Yeah, I feel that committee is worked well, and I welcome that discussion over front around all reports and what level of assurance we're getting. That's been some rich and useful conversation around that. It's also given us a chance to focus and make sure that we are getting the feeder committees. So there are working groups underneath the headline feeder committees, if you like, and that's giving us the opportunity to focus on that and make sure we're getting that right, because obviously both Jay and I and you, that's very real opportunity.
Thank you.
So across the 2 organisations, there are 17 feeder committees, which we just need to understand how broad that church is.
I'd just like to say, I don't think we can underestimate actually the impact and the value of that committee as clinicians, because it's the debate. It's far bigger than the report. So actually, I think the value, Chris, is understated in those papers.
Any questions for us? Can I just raise one? It also relates to the sort of metrics. Complaints, we see response times great, we see problems. I think from this board's perspective, the 2 key questions from me anyway are: 1, how good is our responses? And secondly, how we learn. And I just wonder what discussion goes on there, because how quickly is only one for us to relatively small measure of how good our response is.
Yeah, and it's a really good point, Chair, and one we had a bit of debate about actually. And I think we need to do a yearly pull of themes, so we've agreed to pull that through. The themes are remaining pretty stagnant. The normal themes does have generally around communication and perhaps unrealistic or not sharing realistic expectations in care. Are the things. The response of our the quality of response, I think, was your first question. I think that's an improving picture, and we've got a sort of fairly standard way of how we investigate and hear the voice and the concerns of our service users and their families. But we've got plans to make that better, because I don't think our responses are quite where they need to be, and certainly Debbie and I have been having discussions about how we manage this. I think it's fair to note we have had quite a backlog of responses, which is not a proud position to be in, but we've worked on those, and our trajectory now is that we will be answering responses in a much more timely manner, and I think now is our time to look at the quality of the response.
But do we ask those people how satisfied they are? How well they feel we respond? Do we ask them that?
We
do we sample that?
We don't, and I think what we probably could be doing now is going back and doing a sort of survey amongst some of the complaints against responses. Historically, we've had feedback where we've had particularly poor response, and we've met with some of those families and patients over the last 3 months or so, and there is some real learning there for us, and we've changed processes.
I mean, you've obviously started a discussion, but I think that's quite important. I know it's really difficult, but actually, that's the core of what we should be asking.
Yeah. The other thing I think that we are on a journey with, and we've absolutely started, is we have far more complaints than we should have, and not enough POWs. So I think historically we've moved things straight to a complaints process, which is not great for our complainants. POWs, you will get a response within 5 working days, much more direct response, all of those things are far better. So that's where we're headed, and we've opened up our POWs office again in the last couple of months. So that, I think, we're on a journey with.
Sorry, Kevin, you want to come?
No, I'm sorry, I think it was John.
John?
Yeah, Jane said most of the things I was about to say, but in my short time here, I've seen a marked improvement. So there's exec sign off or exec oversight. I'm trying to use my words carefully. So with an exec and the chief exec say all the complaint responses that go out. So I feel that we didn't know what's going on, and I'm saying the data, like look at the data when the complaints first come in, like it's getting much more timely now. So that's good. The other bit, you know, a lot of these things are communication and mismatch of expectation, and if we can even stop it getting to powers in the first place by getting the people on the front line, if you like, to be having those conversations. And one of the strengths, I think, of the complaint process is those people are involved in putting the complaint responses together. So they're getting direct insight of the problems which are in their gift to solve, if you say them. So I think that's
I mean, I think it's really good, the objection as well. That's not a measure of quality of the response.
No, absolutely. But,
yeah, Chris,
well, yeah, I've sent quite a few back.
Chris.
John's partly covered it. It's this training for staff with dealing with a complaint when it's raised with them at that time. On too many occasions, I've heard go to PALS or write in a complaint. Whereas actually, if you deal with this then, you may solve an issue or deal with it there and then, rather than, and we're involved with one that's, I think, now in its 5th year.
Really good point. Deborah?
A couple of points. So I went to PALS yesterday, and the 2 people that were in there, I said, what do you think would improve our patient satisfaction scores? And without any prompting, they both said together communication. But it's really good that we have that insight. But with respect to the office, they're struggling. You know, if you've got two people in there crying with doggies, which they had last week, you can't accommodate the privacy of that conversation. So it is great that it's back amongst the flow of activity, that they are struggling. And for it to be the best that it can be, we probably need to just have a little look at that. But last time we had a board meeting, of course, Susie and I went to the complaints department, and they said, just what you said, they said, we need to get staff to understand, not only have training, but to understand if they say go to PALS or make a complaint, it is coming back to them. It'll just take longer because they'll have to do a full report. So it isn't just about the education about how you handle a complaint, but it's also about if it goes beyond that point, you will end up still having to deal with it. Better to deal with it contemporaneously.
Yeah, and I've got a couple of points when we move to our children's report. Actually, things we've done there, learning for the rest of the organisation in terms of hearing those concerns.
Thank you.
So if we can move on to audit, please, and Alice.
Yep, thank you, Debbie. It was a meeting at the end of June of many annual approvals. It was the sort of end of our annual cycle, if you like. So we approved the annual report and accounts for 22-23, the annual report and the governance statement for 22-23, and our letter of representation as well to the auditors. And we approved those to go forward to the board. The only thing which is now taking place over the summer as part of that cycle is the value for money audit, which I know some people around this table may have been contacted by Grant Thornton to take part in. Everything previously mentioned, I think, is going to be clean, as we would expect. The value for money audit, I think, is where, if anything, we expect a bit of challenge. And I don't think we necessarily expect that to be a clean report, if you like, for want of a better word. And I don't think we're alone in that, but I think given our financial challenges, that's to be expected, unfortunately. So we'll update the board, obviously, when we get that back in draft and when we know what that's going to look like. There were no significant issues, I would say, coming out of the audit findings report this year in terms of control weaknesses, significant concerns on that front, which was good to hear. And it had been a straightforward and simple audit, and we commended John and the finance team on that, and particularly Fru, who I know is leaving us shortly, as a key part of that team. We also received the annual report from the internal auditors and from the counter fraud team as well. And again, they were clean reports. We also received 2 new internal audit reports for health and wellbeing and data security and protection, the former being reasonable assurance and the latter being substantial assurance. Both good news. I know there's something somewhere else in the agenda. I'm trying to think where about the health and wellbeing teams and a comparison to Northampton, Kettering, as to how we structure those. And I think there were some common lessons there coming out of the internal audit report there. But reasonable assurance that we are doing what we need to do on that front, and really welcome, particularly on data security and protection in the current environment. The other things we talked about were the committee's deep dives on the BAF risks, which we were happy was a process that on the whole worked well this year. We felt there was scope for improvement around how we link that to what we do with internal audit. So where we are finding we have control weaknesses, we have concerns, are we linking that back effectively in our committees when we look at the BAF risks, and some more work to do on that. Another area where we noted significant work had been done, and we thanked the team for that, but there was more to do, if you like, was around the clinical audit compliance. John had prepared a report for us on where we are on that, and this is an area I think that the audit committee has previously perhaps struggled a little bit with, how we balance our responsibilities with the quality and safety committee on that, and that we are concerned about the process, if you like, and they are concerned about some of the content of any findings there. And we were pleased that that process had improved, and we had a lot more clarity about that, but we asked for a 6-monthly rather than annual review of that, so we can really keep checking in on that. And the other thing to say, which isn't in here, but is relevant to the board, is we're about to start the process of looking at a new internal audit procurement process as well, which we're hoping to begin in autumn. Happy to take any questions.
Okay, let's move on then. Finance and Performance Committee, please, Damien.
Yeah.
Thank you.
Okay, well, I'll start with the operational performance, and I think I'd agree with your overall comment, Debbie, that the performance of the trust has been relatively good. There was a couple of things that were highlighted. One is bed occupancy being at 98%, which is obviously incredibly high. I think the target is probably 85, I'm going to say somewhere around that, which I know is probably unrealistically low. But what was also highlighted is that ED attendances have been high in the month of June, and the inability to have good flow through the hospital to be able to discharge patients into care packages, etc., has meant that there have been concerns over overcrowding in the emergency department. So definitely a lot of focus on discharge, I think, for the team and how they reduce that incredibly high bed occupancy rate. So that's the only thing I would say on performance, operational performance that came up. On the money side of it, we obviously had a session in private board this afternoon, but maybe just to level set everyone to the financial position, and I do apologise that at 10:40 I'm going to hurl a load of numbers at you, and I'll do my best to keep it simplistic. In terms of the financial performance as of year-to-date month 3, there is a group deficit of 11.2 million versus a planned 7.5 million deficit. So that gap between what we've achieved and what we hoped to achieve according to the plan is a negative value of 3.7 million. The KGH proportion of that is 1.7 million. Of the 3.7 million gap, 2 million is unrealised efficiency savings that we had assumed in the plan. So just to delve into the efficiency savings a bit more, the plan assumes 54 million of efficiency savings across both trusts, so at a group level, of which 42.8 million is essentially cost out, reducing cost, and the remaining 11.2 million is assumed from activity growth, so doing more. The gap to target at the moment is 27.4 million across both trusts. If we include pipeline schemes, so these are ideas essentially that are not costed, that reduces to 18.2 million. And then again, with KGH, within KGH itself, our proportion of that 42.8 million cost down is 19.3 million. We currently have a 15.5 million gap to target. And again, if we include the pipeline schemes, that reduces to 9.2 million. So again, I apologise, it's probably hard to kind of assimilate all of those numbers. What does that really mean? It means that on the current trajectory, we are unlikely to meet the full year plan, which assumes break even at a group level. And I think when we get to private board, we need to discuss what we can reasonably do about that. And also, I think a piece of work which finance are doing is to look at, where might we realistically land. And within that, we've been asked to produce a 3-year financial plan. And so I'm quite pleased that there's a kind of longer planning horizon that we can consider in terms of trying to reduce that deficit to a manageable level, because I think it will be tough to do that within the current fiscal year. The only other thing I wanted to say is we formally approved the continuation of the committee common approach for FP&R. So that's something we're very happy with, and I think it is very useful to have a view across both trusts as to operational performance, financial performance, why are there disparities, what are the common issues, etc. So we've agreed that, and I think that's a good thing. All right, that's probably all I wanted to say.
Thank you.
Thank you. Just to add a couple of other things that have that the trust have been working on in terms of financial and others. Assessments, just to say we have been asked to, and we have submitted a return on the potential impact of industrial action on across the two trusts, both in terms of the impact on the pay bill for that industrial action, but also early assessments of what that's potentially doing to activity. There's a number of caveats in that return that we've submitted, because it's at this stage we're only able to quantify the activity that's been formally cancelled when there's industrial action. What we're looking to do is to say, well, actually, what further activity was prospectively not booked, because we knew that there was industrial action around the corner. So we've heavily caveated our return to say that that is the easily quantifiable activity impact, and there will be further impact, and we're expecting NHS England to ask for those returns on a regular basis. What that also is doing, NHS England have looked at, colleagues will be aware of the Electric Recovery Fund requirement in the ERF income, which is basically around us securing income based on that electric performance. As a result of the April industrial action, and only the industrial actions for April so far, NHS England have announced a revision to the target. So all trusts were in aggregate across the country required to improve activity compared to 1920 levels by 9% nationally. NHS England have agreed to reduce that target by 2% as a result of the April industrial action. They'll continue to monitor that as the industrial action continues, and potentially change the targets again going forward. What that's doing is meaning that it's quite difficult to confidently confirm our position as we stand at the moment against that target. We've done some assessments. The first couple of months would suggest we're behind trajectory in terms of that, but of course we need to play in that update to the target, and also those early assessments are based on non-final data, activity data, so as data is finalised through the submission processes, that improves the position. So we're working on confirming those. The other thing, just to say, just to add the timeline for the medium-term financial plan that David mentioned, we've been asked for a very high level sort of first cut, as it were, 21st of August, and an update by the 25th of September. I'm referring to that as an update, not final submission, because I know how these processes tend to be quite iterative, but that's just to give the timeline that we're working to.
Matt, is there anything else that you'd like to?
I suppose it's just kind of following a little bit about the industrial action, the impact of that continuing with the industrial action planned for August from both the junior doctors and the consultant body, and that is impactful significantly on our finances, but also on our activity levels. So it's just to be cognizant of that and the impact that is also having on some of our operational performance. We are managing that and planning that as best we can to mitigate it. However, it continues to be significantly impactful on the ability to deliver what we want to.
Thank you. Some of this may be appropriate for this afternoon's conversation, so I'm happy to defer some of it if that's the case. I suppose the first question, it follows on from Debbie's point earlier around, I agree when you look at the IGR metrics, actually things are we'd like them to be better, but they're in a relatively good position. But that doesn't necessarily seem to tell you what we're seeing on the ERF funding results. Is that just around the industrial action? I'll say just, I'm aware it's a big just. Is that just that, or is there something more there? And also when we are in regional discussions, this may be a question for Debbie, are we getting the sense that that sort of balanced scorecard is being taken into account, or is it very much you've got to do well on this and you've got to sort all the money? Because there's a huge interlink there, isn't there?
Sure. So there's a couple of factors in terms of if we look at ERF performance. The trust set itself a plan of elective activity that recognises that performance will improve throughout the year. So the first couple of months, the elective recovery plan activity, that is only a subset of all activity, was set relatively low, recognising there was likely to be a growth as plans were developed and focus brought into that delivery sort of as the year progresses. So, and also the important part is that it is only a subset of overall activity. So what we're working on within finance with Health colleagues support is to try and be a bit more clear in how that works through. So as we look at the IGR and we're seeing all elective activity, it's got a number of areas. So some of the women's activity is not included in the ERF, it's excluded from the measure. And so we're looking at separating that out to say, and we're calling the phrase ERFable, of all of our activity, what's ERFable, so that we can actually perhaps separate that out a bit clearer for those, because it is very difficult to look at one metric that says activity is at a particular level, but maybe finance is saying that it's financially it's not quite where it needs to be. But it does recognise, as I say, that KGH set itself its own plan to be below the national aspiration in the first few months. So inevitably where we are is below from an ERF measure, with the expectation of catching that up in future months. And so it is a very complicated picture. The other thing I would say is that the information that's in the finance report that's in front of you is based on draft month 1 and month 2 activity extrapolated. We are refreshing that, and I was given some updates yesterday that say actually that is an understated position, so it is worse, but it's reported worse than is actually delivered. So there's some recovery in these numbers that will come in subsequent updates. Very badly worded, but it will get better in the next report.
Your second question, the answer is you have to do the work. Having said that, there is a bit of flexibility. If you're doing really well under activity, then they tend to be more willing to give you some help on the finance. Similarly, if you're doing really well on the finance, you can boost your activity. But the scale of that is limited. And we have to really focus on the finance now, because the last thing we need is to be under special measures and lose control of our destiny. And, my own view is that actually we're not doing enough. And we talk to some of the more execs and Trevor, etc. I think we can just one example, banking agency.
Indeed.
Many trusts, we are behind many trusts on a banking agency. I really don't know what's different about Kettering or Thankful to even places where, you know, they still use it, or Wolverhampton, which is eliminated. So, you know, why are we different? And I think, you know, we are going to have to, we'll pick up some of this discussion, we are going to have to focus on. I think it is good we've got 3 years, but actually, if we don't perform well, whatever we mean by that, if we cannot demonstrate that we've done a really good job in finance this year, that we won't have the ability to determine our own destiny in the next 3 years, we will be hugely controlled. So I think there's a real prize there for us to get on top of finance. So, you know, these things are always a bit grey at times, but still, we have to, you know, we can take out one-offs and things, and we can deal with those in a different way, in a more money. But actually, the core underlying position have to be making some this year, if we are going to have confidence to start negotiating 3 years.
Sorry, Charlie. Just, mine was on a different point. So, yeah, so we start out with the plan. How engaged is this just the finance department putting together for you? And how is this actually engaging with the divisions and the rest of the trust? So this is actually where we're all signing the bottom line. So not 100%, but this is our best estimate.
But absolutely, this is to a certain extent the timescale has landed on us a bit, so we are in that process at the moment of working out exactly how we're going to widen that out. What it does work alongside is the integrated business planning processes that are already in place, and so we're looking in terms of timelines and just exactly how that rolls out on a very practical basis over the next few weeks. It is finance sort of, you know, expanding out, working with divisions, working with relevant colleagues to focus on the current year position, to say, let's firm up our forecast, let's make sure we've got a really sort of rock steady view of this financial year. For future planning, to a certain extent in the first iteration, it will be quite a high level, as a lot of these planning processes are, giving us really more of a focus for the September submission of saying that's when we really expect to probably see more of the detail and more worked up. So it will be relatively high level for that first August submission for future years, because the focus is really on, let's make sure we can nail a number for 23-24 and be very confident that is encapsulating with the work that's already going on to identify, as we mentioned earlier, pipeline efficiency schemes and the full article possible.
So my secondary issue is actually a question, which is unless you can answer at this point, but is about the governance around signing off those plans in terms of who needs to be cited, where do we sign it off. Not overcomplicating that, but we do need to make sure that this is what we're submitting, that this is something that the organisation is signing off. And I know there's a lot of hard work goes into these from the finance perspective, but also within the us to follow in terms of where the people piece plays into it. Because people and activity are two critical communities.
I mean, I think both of the actually I think, you know, as we talk through this, because all finance is a reflection of people and operational stuff, and that sort of stuff. Yeah. So I think that first one is such a confidence there for the board to understand how sure we got that. And I think we can come back to that later, but I think there's two really good points.
Chair, if I may, just for public board, just to give assurance, any changes to any clinical cohorts of staff are going through a very robust QIA process that both medical director and myself have oversight on, so we are ensuring that we're maintaining those staffing levels.
Couple of questions. First, around the industrial action, could you just summarise where we are? And a query around that, I've heard that some of the junior doctors, specialty trainees, are starting to worry about impact on their expectations of work because of the strikes, etc. So I wondered if that was an issue. And the second one is, did business and performance actually discussed the disparity in elective and patient activity between us and NGH. NGH seem to be doing 127% and we're at 90%, but yet we're higher on day case. So I'm wondering what the conversation was around why we're not doing as well.
Should we go to industrial action first?
Yeah, just so I understand that question, are you saying that we're putting undue pressure on the unions to work?
No, I'm saying that they're worried because certainly with the consultant strike, elective lists were cancelled and now they're starting to get pressure about the number of hips or knees or procedures that they have to do.
So, yeah, so I haven't heard a lot of noise about that, but that is being picked up by the daily, but
okay.
You can't have your cake and eat it.
Okay, I'm sure you'll mention although I think the sensible.
And in terms of your first question, Lisa, what do you want to do an overview of it?
Just where we are in the next month, because I know the junior doctors are out to ballot.
Yes.
But yet they they've introduced a strike before the end of their.
Yes.
The strikes in the week leading up to the August bank holiday weekend, the juniors are on strike the weekend. He incorporated the weekend before, and the consultants on strike the Thursday and the Friday before the August bank holiday weekend.
And I think what we need to recognise is this is actually really difficult, and it's getting reported through code. I use of strikes, etc. And people after a while will run out of resilience to support in different ways. We've seen some of that happen with our junior doctor strike. I think we just have to support people and try and make the best of it. But it's not an easy one. I don't think widely across the NHS there's some consideration of these strikes. So I think that the other thing which, to be fair, was picked up is we need to keep an actual record of its impact on our performance. So there's the staff bit and the patient bit. Actually, did you want to say?
Okay, thank you.
Sorry,
Very Richard for putting it together. Sticking with operational performance rather than finances, I reckon I'm going to use that. In the papers, it references around nursing home capacity reducing, and I just wanted to expand on that a little bit. What's the latest status with that, and almost what's next?
Yeah, so I think nursing home markets in Northamptonshire is under pressure, but I think this is similar across the country with staffing levels and pay rates that have been available. So we've had in the last 2 weeks, we've seen calls to nursing home, 19 beds shut. Northamptonshire actually trains those patients across the piece, and for us, that's probably the most pressured pathways for patients who are requiring support to go back to nursing homes in particular. That's the one that is most delayed in terms of us trying to, so on average it's 19 days since somebody's medically fit before going to a nursing home placement, and that's our longest support pathway. At the moment there's a lot of work going on within the county to look at how we can try and look at different ways of delivering that pathway, although there hasn't been any magic bullets or white charges coming over the hill with that, but there's a lot of work going on, and it still poses for us our most challenged supported discharge pathway.
But I think this is another good example where we see what learning goes across the two. It may be that the care home market in Northampton is quite different, but they've actually recently done some quite significant moves on discharge.
Yeah, particularly on their pathway.
So I think whenever we see, whether you're Northampton or Kettering, whenever we see one of us doing well, that's what we need to do, is go knock on their door.
So we are in very close conversations. I think that halfway through situation is very similar to ours. What Northampton has seen most recently is a significant change in the pathway to changes, and that's mainly driven by their stroke rehab beds and their beds. And that's been their biggest.
I mean, there may be good reasons for it, but we should just need to sort of maximise that learning.
Yeah, they've also seen quite a big difference with Pathway 1 recently, haven't they? And the learning that they've taken is from the way that we manage our digital so it's. I
mean, I think this learning is going to be.
Yeah, it's important.
Absolutely. 3 ways when we're investing in our home in 3 ways.
So there's lots of overlap and operational teams between Northampton and Kettering in terms of our history, so we are.
Okay.
I was just reflecting also on Alice's question, I think it's Alice's question around the part of, is everything important? Finance, performance, quality, and the system had their quarterly review 2 weeks ago with NHS England, and they congratulated us on our performance, but were very clear that they wanted it to continue and that we clearly needed to do more on the finance, which of course is what we are saying. But I think the conversations that we now need to start having, certainly over the next couple of weeks, our pipeline continues to grow with our efficiencies, which is great, but we are now into the difficult box, and we do need to start having some conversations as a board around, do we push our outpatient rates out, for example? So at the moment, we are the best performer in the region for 52-week waits, and we might want to take a difficult decision in the very short term about what we do around that. So they're the sorts of more difficult discussions that we need to start having now as a board.
And the real part on the risk appetite discussions as we get into the detail of this.
Yeah.
So I just wanted to come in on the elective activity difference between Kettering and Northampton. So some of it is a slight artefact of the plan because it's a percentage of the plan. The plan figures are actually very similar between Kettering and Northampton. They've actually got slightly more capacity and their phasing and the plan increases throughout the year. Having said that, there is still a kind of a difference in terms of actual activity between the two. Northampton have had a couple of really, really good months with their theatre productivity, and there's been a real focus around starting on time, which has really driven a massive increase in kind of April and May, over and above where we were expecting theatre productivity in Northampton to get to. Whereas Kettering has been improving for a while and then has then been kind of relatively plateaued, but they've kind of had a bit of a jump. So that's probably the kind of two major reasons why there is a difference. But looking at the figures for the next month that isn't included in this report, Kettering does go up in terms of performance against the plan.
Should I move on to group people? And Deborah, please?
You've discussed everything. That's fine. So the two meetings since the board last met, our chief people officer report is key to it. And you've just rehearsed very much what we've been discussing, so the balancing finance, we directly affect finance with our agency and bank spend. And although this month we didn't have access to up-to-date data when the meeting was held, that there were no real surprises and we did see it, agency and bank spend are still key. What we have been querying in our meetings and discussing more greatly is absence. Why are people absent from work? Not just sickness absence, but other planned absence such as annual leave and study leave. How are we managing those? And equally, we have other. Is that parental leave? What exactly is that, and how are we managing it? So we've been having a lot of discussions about those, and we haven't reached the point yet where we've got plans. I think that's the discussion, greater discussion amongst us all. What's really key is culture as well as anything else. We've just heard that this morning, we don't need to be advised about that again. But we've had some national drivers come out. We've had national drivers around workforce planning and EDI. And it was the feeling of the committee this time that they ought to have a focus on our development sessions, not just as a one-off, but as a continuing thing, that we need to keep exploring these and making sure that we are moving at pace. And that was a concern of the committee, that the pace, especially around EDI, probably wasn't. We needed to understand some of the dates that were attributed to that project. In the June meeting, we had a paper on attraction, resourcing and retention, and we were reasonably assured. Again, the lack of, if there's any hesitancy, it's about our banking agency and how we are going to address that, and it always comes down, really tends to come down to our absence rates. We were very substantially assured around our gender pay report in the June meeting. We felt there was great understanding, and we felt that the challenges were triangulated and we understood how to manage this, and we were really, really happy with that report. So this month, We had reasonable assurance around our employment relations, and actually what we're seeing is that if you are from a non-white background, that you are not more likely to end up in a disciplinary process, which was assuring. We did have some concerns about the duration of some of the cases that were ongoing, and so we've asked for some more details on that. It wasn't excessive, but there were 1 or 2 cases which have been going on, certainly here, or 1 case in particular for a year and a half, trying to understand why that is the case, and where that is related to the ability for an executive member to attend a meeting, or in particular maybe a union. We need to be pushing back at those. We had substantial assurance from our volunteering report, and I think you can see here we felt that without our volunteers we would struggle to actually move forward on a daily basis at the moment. And I have made a point of going to talk to some volunteers and just to see how they're enjoying things. Are they enjoying things? And the answer is very much yes. We signed off, we were substantially assured by our RRO report, so thank you, John, and that can now be signed and confirmed. And we were unable, as a convened committee, Jane, to give any assurance around the stacking report. It was a dreadful day of the meeting. We had a strike. We had doctors we were struggling to maintain our quorum in that meeting, and the Northampton member was a deputy attending another Northampton member. We just couldn't. But from a catering point of view, the deputy did provide assurance, and again it was really about our headroom and our absence rates that were providing us with some degree of concern, really. But was assured to see that there have been no major incidents in relation to any absence and headroom issues. So that's the report.
Thank you. Well done. And just one thing, we've talked about a lot this morning around learning, and we've also been listening to Amanda and her story. And there have been 2 very high profile cases nationally recently that have involved the NHS and nurses in particular who have had a positive experience. The Fox case, which is Manchester, and the case of Shape, which is London. So I convened a workshop with senior colleagues from the employee relations team in both organisations this month. We reviewed those cases, we looked at the learning from those cases, we considered what that meant for us, and those colleagues have agreed that what they need to do now is to take firstly that workshop case review learning process to wider members within the team, including colleagues from the recruitment team. But we're also going to come back in September after the holidays and look at our own cases and review our own caseload against those external cases and ensure that where we've got cases that impact race, that we think we have done everything that we should have done, and we've looked at those very much on an individual case-by-case basis rather than applying our policy too rigid a way, which is sometimes where these things fall down.
Thank you.
Thank you.
Group Strategic Development Committee.
I'll keep this fairly brief because on the first item, we've actually got a paper item number 9, item XX. But our limited assurance is not about what we're doing internally. We are trying to adapt our internal processes to try and be on front foot when we do know what's happening. We'll come back to that. And similarly with the Energy Centre, our limited assurance was more about the external process, given the level of risk there is at KGH on the inability to replace the electrical infrastructure and particularly boilers. So work is underway, but actually getting the work underway is delayed due to the fact that the national process, in part due to the national process, there's some internal issues there. The third area was Community Diagnostic Centre, which our assurance around that was because we haven't got a temporary solution in place. Our assurance would definitely be limited, given that the badgers have got in to the, I say got in, we're already there. Corby and our causing significant delay because of what we have to go through to encourage the managers to move elsewhere to actually build a new community diagnostic centre there. You couldn't make it up. And finally was the area around risk, because a concern we've had for some time is about aligning the risks that sit in this programme with some of the risks that they come through the hospital, which is part of the reason why we have, for example, the energy centre. We're moving ahead on the energy centre because it's a very high risk area, but actually making sure we're aligning the risks within the programme and likewise with what goes on in the trust. That will be even more important as we go forward with the programme and how we take decisions about the nature of how we do it, not just waiting for what the centre says, but actually looking at how services might be co-located, which services do go into the hospital and which don't. So there's a whole range of things. But I'll keep it brief. That's the strategic development.
Holly, anything to add?
The only thing to add is the third CDC that we did get approved as well nationally, because that's not picked up on here. So whilst that comes under Northampton Board's jurisdiction, it will be a facility that should be able to be used by our patients in the north as well. So we are just going to get started with sorting that out as well.
I didn't know where to bring this up actually, but this, because you've mentioned IGR, culture for me is key to everything. It doesn't matter whether we're talking about finance or whatever. And I looked through this and I spotted under, it was just happened to be under infections, hospital-acquired infections and mitigations, and it talks about lapses in care. And in a just culture, they're just not words that sit easily. So when you're looking at the IGR, I really appreciate it as opportunities for learning. But not lapses in care. And I know that seems to be picky, but if we're talking about culture and we're talking about those values behind us, it has to be everywhere. It can't just be in the discussion.
Yeah, it's a really good point actually, Deborah. Thank you. We'll take that.
Yeah, so that way.
Yeah. So finally, Group Transformation and Digital Hospital Committee, please, Andrew.
Yes, so this was the first meeting of the combined digital and transformation committees. Fair to say that we're not happy with where it is. As the first meeting, a bit of work to do there. Too many agenda points, too rushed, not enough time to get into substantive discussions, but we're committed to sorting that out in the coming meetings, and we're going to be trying to get through this. Just some points to pull out. The first one was IGR, and recognising Debbie's point about the considerable work that's taking place. But however, the report that was in the pack for the meeting was quite scathing. The feedback was quite scathing about the document. Lack of confidence around data, executive sign-off being patchy, clunky process. So, yeah, to name but a few, so a bit more work, quite a bit more work to be done. And also a reflection on the fact that on the IGR, I think it's in this business pack, there's 128 metrics, which is a lot for any organisation to make sense of, or to prioritise, or to come up with action plans. I think we do need to reflect on that as we move forward. And of those 128, 88 fell under the heading of, and I quote, consistently anticipated to not meet target, or not consistently anticipated to meet target, which is a nuanced use of the English language that I don't fully understand. But I take it that they're missing. And I think that I feel that we're not quite sure, we're not able to focus on the key areas where action needs to take place. You know, we're almost almost out of luck as to how we pick things out. So there is more work to be done around prioritisation, I feel. So we're going to be tackling that in the forthcoming meetings, and we'll come back to this about it. But at the moment, we've got limited assurance on that. A couple of other things to pull out. We had an update from Kirsty Watson, the ICB Digital Director. 3 things to pull out from this. The digital maturity assessment was extremely disappointing for Kettering.
we were assessed as being either bottom or close to bottom for all of the domains that it covered. So not a good result there. The timescales that we felt the ICB were working to were unimpressive in terms of what we need to resolve or come up with an action plan. But Northampton ICB has identified digital data and technology as a key enabler, which was a relief that they have done that, and that Kirsty was confident that we're going to drag ourselves off the bottom of the pile the next time this review takes place. But we need to reflect on how we can influence the ICB more in terms of where we are on digital. Also introduce more pace and urgency into how it operates. And also there's a complete confusion about where the line is drawn between what the ICB is doing and what the individual hospitals are doing. So we need to clarify that as well. And we'll have to pick that up in forthcoming committee meetings. A couple of other points. We had updates from the digital enablers for clinical collaboration, where a number of elements are already in place. A number are going to be delivered over the next couple of months, but also there's a number that still have to be delivered, and regrettably a number that we haven't got agreed delivery dates on or confirmed funding, and I know the team are working on that. And we also had an update on outpatients transformation programme to improve outpatient service. This is early days of this programme. And we recognise it was early days, and as such only gave it reasonable assurance, but we felt it was a good plan, and we encouraged the team to really use it to get on.
I'm going to move us straight on if I can. I want to say thank you for that report. It was Danny with eight praise, I felt.
I tried.
Sorry, we're a bit behind, and Jonathan will know that I'm true, but shall we take the health charity report now, and then we can come back and after the break, we can select the children to talk to otherwise we...
Yeah, no, happy to do that.
Is that right?
Yeah.
Thank you.
So, good morning, everyone. My name is Jonathan McGee, and I'm the new Chief Executive of Northamptonshire Health Charity. I took over about 4 weeks ago from Keith Brooks, who's retired.
Oh, sorry.
So what I'm going to do is take you through what we've done.
The little icon.
Just on the ground.
That one there. This one.
Left of us.
Yeah, that's it. Do you want to go back? So,
Richard, you might want to minimise the KGH board.
So I'm just going to take you through what the charity's done over the last year, what we're hoping to do this financial year, and where we hope to be going in the future. So next slide, please. So we're pleased to say we spent over 1.3 million on charitable expenditure across the trust last financial year. So I'm going to take you through what a few of those things are. My ambition coming into the charity is to, I'd like to double it, not triple it, but I need to work on the numbers and look where that money's coming from. But we've got ambition to grow the charity, to get more income in, and spend more across the trust. Next slide, please. So here's an example of how we're supporting patients and their families. The charity helped fund the ICU rehabilitation garden. I believe that the average stay in ICU is about 21 days. So having some spaces where people can be with friends and families to have to be outside of the hospital walls is really helpful for recovery. So I think the charity is looking at what we want to do is to be able to support prevention, diagnostics, treatment, recovery environments. So doing this sort of thing is really important. Next slide, please. Charity also funds medical equipment where there might not be NHS funding, so it funded 10 of these reminiscent interactive therapy activities, or RITA, which basically allow elderly patients to relax more within the hospital setting. I think this quote is quite interesting, that an elderly patient was in distress in ED, and they used the RITA system, and that calmed the patient, and they were relaxed within the environment. So these are really important. Next slide, please. So we funded other equipment. I can't claim to know anything about what it's do, but that's for helping train doctors through to testing patients who are not mobile through these government e-bike, through to providing kits for parents who have had previous baby loss but have new babies. So just kits that help give them the right stuff for when they come into hospital. So we continue to support patients through the charity's activities. Next slide, please. Here's a few more examples. So providing furniture for rooms where urgent care staff have to break bad news, sadly, but just having more comfortable furniture and better environments just takes some of, it doesn't help, but it alleviates some of the stress. And then yoga sessions for cancer patients. So there's a lot we're trying to fund. We want to do more for patients, and we'll keep doing that and identifying where we can spend money. We're going to change the structure of the charity around a bit to have someone identifying, and that will be their role, to identify where we can spend money in the trust. Next slide, please. But of course, part of supporting patients is also supporting staff. Without the staff, you don't get the care that the patients need. So we really want to start supporting staff more. So far, the charity has helped support the Staff Excellent Awards, which is really important to recognising staff. Next slide, please. And also it's helped fund furniture and equipment for the ICU staff area and provisions for the care cafe. At the moment, we're running a £75,000 campaign to try and get some funding from corporates across the county, and we want to use that money for staff wellbeing. We're looking at how we could use that to improve staff rooms across the trust, because I think that's really important that staff have nice places where they can decompress and switch off. They're not about training, they're just about them and relaxing. So hopefully, as we bring that money in, we'll start improving staff across the trust. Next slide, please. And these are just some other examples of where we've been able to help staff across the catering site. Just trying to think where I am. Next slide, please. This slide is, as I said to Northampton yesterday, it's not to gloat about the charity. These awards are really about recognition of what the charity does for patients and staff. So it's the community saying we value what hospitals do. They give us the awards, but it's not about us. We're just facilitating the community giving their support and donations to the hospitals. Next slide, please. And so just to reiterate, we want to do more for patients and importantly more for staff. Like I said, we'll have someone dedicated to expenditure, identifying what those areas are and how we can support the hospitals and the trusts. We want to increase the income into our general funds. So we've got hundreds of funds across the trust. Some of those funds have got not very much in it. And what we want to do is get to a position where, rather than award a department having 100% of not very much, be able to access a share of a huge pot. And that means we can do stuff across areas, we can be more strategic. So for example, if we want to improve the staff room in in the area and they don't have much money in their pot. With the bigger pot, we can make those transformations. It's a bit like sharing tips in a restaurant. You give a tip and it goes everywhere, because not everyone who's involved in patient's care and on the patient pathway will benefit from donations. People tend to give where they perceive they've had the care, but they won't see all the different departments involved in that care along the way. And some areas, like I know, for instance, in Northampton, the mortuary area needs, the visitor area needs some furniture and a bit of care and love. And there's no money there because we could donate. So we want to encourage that, just supporting your local hospital. Please help Kettering, please help Northampton. So that's where we want to get to. Bigger pots of general unrestricted income means we can do more. And just to say, the staff fundraise. It's not limited to people outside the trust. People within the trust can help fundraise as well. So yeah, we're going to try and spend more, raise more general funds, make it easier to spend funds as well, and to access funds for the staff applying. And that's it. So, thank you.
So I think it's really good to work with you. It's fantastic support.
Thank you.
I've been here that long already, I've seen that, and I know that's felt very widely. So, Paul, can you just thank you and also pass your thanks on to your people and colleagues? Any questions?
Thank you. Just three very quick comments. So really welcome the general funds. I think that's really important because there are places in the hospital that are perhaps not as sexy, let's say, as other areas, such as like the mortuary, for example. So really welcome that. I think really pleased as well to see, since you arrived, some of our charity staff out and about in the hospital and visible. Really welcome that. I think that's really important. And then just to remind colleagues around the board table that we have got a little fundraiser going on in Glebe at the moment upstairs.
I think your point about visibility is really key. We need to get out there more and more, not just for patients but for staff as well. So we will be increasing that over the coming years.
Thank you. So thank you very much for the work that the trust does. We've already had a fairly challenging conversation about finances this morning. We're having another one this afternoon. Clearly we're in difficult times. We've also been hearing about the importance of culture, and it's then been more important that we look after our staff in every way possible. So just wanted to thank you for the work that you do, because those things that you do for staff, whether it's the ability to go outside and sit in the fresh air and have 15-minute break, or other things that you do in terms of the recognition events and things, it really does make a difference to the experience of our staff. So thank you, and never more important than that, I think.
Just a very brief plea. Before we joined the county health charity when we had a local charity here, we had this same issue, and I think that it's around visibility. And whilst I think we've perhaps improved slightly on that, still walking around the hospital and as a patient or a patient's relative, I don't think it's very visible to the patients yet what the charity is and how they might give. And I know lots of charities now are very good at making it very easy for you to swipe and give at every possible opportunity. And it was just a plea that, I know we've been saying this for a number of years, but can we get even better at making it easy for patients and relatives to give there and then while it's in their mind?
100% agree. So before joining here, I was at Addenbrook's charity for 5 years, and we did a massive push on visibility and making it easy to donate within the hospital estate. That's really important, like I said, for patients and staff, so they know what you're doing. And it's also about providing multiple opportunities to give. So whether that's contactless, which actually washes its face, cash is still king. Cash drops, we're just pulling in thousands a week, apart from during COVID, probably 3 seconds, but also donation envelopes, etc., QR codes. So the more opportunities to give, the better. But that's on my list.
Good. Thank you.
Just very quick, because you need to be aware you're reaching to their coffee shop.
Just on the point of, making it easier for staff to access, I think as an organisation, we do need to work on with our advisors to enable them to do that, to use the processes you've got. I say that as a trustee of this charity and deputy trustee with me. We need to make it so that they are able to apply in a way that you feel is appropriate, because it's considerable amounts of money sometimes.
Thank you very much.
Yes, thank you.
Thank you.
Listen, if anyone's got questions, just drop me a line. Thank you.
Right, a 10-minute break, so back at 11:40, can you just on where people were allocated 20 minutes or 15 minutes, can we just show you 5 minutes on each of those items?
Sorry.
Because we do need to get out, be there for the, so we have no scope to extend. Is that right? CQC report, and 15 minutes. Slightly less.
Yeah, thank you, Chair. I'll take this on. Thank you. So on the 26th of April this year, we welcomed 5 CQC inspectors into our organisation for an unannounced visit. They visited Skylark Ward, our children's ward, our neonatal unit and our paediatric emergency department. And this was a follow-up visit from the visit in December. So therefore, they looked at 2 key lines of inquiry, which was safe and well led. And that is why we was unable to be re-rated at this visit, because it was 2 key lines of inquiry, and CQC are unable to re-rate just looking at those 2 focused areas. But when they come back, we will welcome them back, and they will do a more thorough report, and that will be our opportunity for re-rating. Just before I pull out anything from the report, I just wanted to make a point of saying that the hard work, and I hope colleagues have read the report or at least seen the headlines of the report. We're really proud of this report. There's some real achievements and success in here. And I just want to make the point that it's not about just the hard work of our doctors and our nurses. This was the hard work of everybody. Our pharmacy team, our estates, our facilities, our allied health professionals. It was probably one of the biggest pieces of work we've done, where we've taken everybody on the journey, and I think that is why we have achieved what the teams have achieved, what they've achieved in this. So I just wanted to make that point. The report, I think, outlines really clearly some of those improvements we've made. Certainly how we're hit, they spoke to about 27 members of staff, I think, and again across that broad spectrum, lots of patients, lots of families across those 3 areas. And I think the thing that really struck me, and I think I was most proud of, was that we are now listening to our families and our service users' voice, which I think we reflect on our previous inspection. We weren't doing that as well as we could have done. And certainly up on Skylark, we have invested a lot of time in some really dedicated focused work about listening to what our patients and our families are telling us. And we've moved that work now to business as usual, which I think is a really healthy place to be. And just picking up on a previous board comment, and I think, I can't remember, I'm looking around the room, somebody made the comment about, oh, Chair, I think it was about learning and listening and the quality of our investigations and complaints. Actually, I think we've now in a position where we can really learn from our children's services and pull this across the rest of the organisation, because it is going in and being, up front and saying, how is it? If you're in a hotel, you're in any other kind of service that you were using, you're asked regularly, how was your stay? How did it work for you? What can we do better? And that's the point that we're now reaching in our children's services. So there's that learning to take across. So we clearly improvements in the report. Obviously happy to take questions. I think it's what next really for us. So there are some key parts in there which we are still on a journey with, and we've still got some improvements to make and embed, but it is what's next. And I think the biggest thing that we're now doing is saying, well, what does good look like? And I'm not talking about CQC regulations now. It's about, as a team of professionals, hearing our patient voice, our staff voice, putting all of those together, what does good look like in terms of a good service that's robust and safe and available 24/7? You don't get one level of care at 2 o'clock in the afternoon, something different at 4 o'clock in the morning. And we're getting that voice now coming forwards from our staff about what could and should good look like. And so they now have a vision, which I think is the biggest thing to embed in and sustaining change. Chair, I wonder if I just pause there?
Yeah, no, I mean, I think that's a really good philosophy looking forward, actually, but we can sometimes get too hung up with ticking all the important detail, doesn't it, actually? Yeah. So I'm really pleased to hear that. Any questions or comments here?
Jane, obviously brilliant piece of work. My question is, the situation in Skylark, as was found, was there for us all to see. So how can we assure ourselves that we don't have a similar situation somewhere else in the organisation, perhaps in 6 months' time from now, when, you know, we've all moved on and there's some other challenge that we're dealing with.
Yeah, you're absolutely right, Paula. So a couple of things, just to comments around that. So we're back on our journey to outstanding, which is our trust meeting. So we reintroduced that in February, and that was every other month, but it's now every month with a working group in between. So that is to really focus and really drill down into our services and understand where we are against the CQC requirements, and also what we're doing really well and how do we learn from that across the other services. So that's now well represented. We have our non-exec director colleagues on there as well. The other big thing that, and forgive me, John, because I say it at every opportunity, these are not nursing action plans. So we have really embraced and make it absolutely part of our choracy that we have medical representation on those meetings and the wider staff groups. So really engagement facilities, etc. So that's one thing we're doing. Part of that as well is looking back to reports from 2015 and putting those actions through and refreshing ourselves and making sure where we need to be. We are introducing a quality framework across all of our services, which have 6 main pillars, which I have shared, and maybe Chair, it's perhaps an item to bring back here for a bit more detail at future meetings. But and that really looks at how do we assure ourselves of quality. So, and I've started posing the question to our band 6s, 7s, matrons, heads of nursing. How do you, when you go home, know that the services you're leaving behind are safe? So what are those quality metrics? I think we've spent a lot of time focusing on audits and reviewing services through a checklist type process. Actually, that doesn't give me quality. So give me assurance around quality always. So they are important. We have trimmed down some of our audits actually because some of them have no value. And we review those quality metrics that are important every Friday morning at our harm review meeting. So we're looking at the normal sort of nurse indicators you'd expect around pressure ulcer scores, etc. So that's one framework for assuring ourselves of quality. But the biggest thing is about being out there. And I think we've started a programme of work about how we get the voice of our board managers, how we get the voice of our matrons much louder, how we get them away from these screens and meetings and actually out in the clinical areas, and what should they be looking at when they're out there. So that's the framework that we're starting to look at.
And have you got sort of cross cover, so people are looking at areas that are not their own, and how confident are you people have got the courage, coming back to Amanda, to call out when somebody's not right?
I think staff are getting slightly braver, and I don't think this is to do with racism or protected characteristics or anything else. I think this particular question you're asking actually is about all of our nurse leaders, and I think what we're readdressing is actually what are you here to do? And yes, you're here to make sure we've got capacity and things, but it's also about making sure those services are clinically led and driven. So you have a voice when it comes to quality and the services we're delivering and those patient outcomes. Speak up. So I meet with them all once a month as a group of board managers, as a group of matrons, and we're starting that. We're also starting to peer review, as colleagues around the table know, our 3x3x3. So they're not just doing that in their own area, they're doing that across the organisation, and we have monthly themes. So I don't think we're there yet though, Paula. I think we've got some more to do because I am still worried that we have sections of staff who may not feel they're able to speak out.
Can I just add on to that, because I think there's a theme that's come up in a couple of things. So falls and documentation, paediatrics, kind of that lack of external views about where good is currently. So I think we just need to build on that. It's not just about internally within Kettering, but it's about how do we take people who've been in post a long time, which is great, but also as part of their career development, take them outside our organisation to see what an outstanding team is, so that they come back and they go, oh, actually we could do that. So it's kind of stimulating that
And just building on that a little bit, we've been doing some work with Leicester, particularly as we're talking about children and young people's, looking at our practice development processes and opportunities, and they've been really helpful in coming and reviewing that through an external lens and giving us some ideas. We also, and I have it on my list, it's remiss of me not to say, is I really wanted to say thank you to system partners for supporting this, because we've opened our arms to them and welcomed them in to do peer reviews in all of those areas, and we need to continue that.
Thanks.
Just picking up on what Nick said, actually appraisal is key to that, and it's something that we need to improve, because appraisal is not just about whether you want to go and do a master's or not, it's about whether you can go out into the system and develop those skills outwardly. So for me, it's one of those metrics that not metrics, one of those things we need to change.
So, sorry,
in my previous life, we had a thing whereby you could ask Andrew or tell Andrew, where anybody in the organisation could send an email which was confidential but informal, just advice or suggestions. Have we got anything like that here?
We have, so Debbie Weekly opens up to the organisation, and all staff across the organisation can access either Debbie directly or any one of us.
And there's an individual email as well.
Okay.
Yeah, colleagues can contact me. Rarely, actually, but I do get a lot of people come direct to me, as do the other execs, actually.
The other thing is freedom to speak up, so I meet monthly with our freedom to speak up champion, just to make sure I'm picking up on key things across the organisation.
Okay.
I mean, yeah, really good to hear that, really good process. I'm left with two questions, which I think we might ask the quality committee to reflect on a bit. One is, we picked up from Paula, why did it take a CQC report to trigger this? And actually, what was your wider lessons? It seems to me essentially the question you asked, I think, which I understood. The second one is, of course, there's all professional staff and processing stuff and everything else. Actually, what advantages are there in working in a wider group, which we're trying to get going? About doing some of the things you said.
Yeah.
And obviously, again, people have to learn to time and sit around, but actually, that ought to be one of the functions of the group, to share lessons, to do peer reviews, if we've got concerns, those sort of things. And I just think it'd be useful to just, not here, but to follow up on some of those discussions, perhaps, and think actually what are the implications more widely, just clear.
Yeah, you're absolutely right, Chair, and certainly I've been sharing with Milton Keynes some of the lessons we've learned from our CQC experiences with children.
Trust, so it doesn't have to just be within the three.
Yeah,
but,
that's right.
There's no reason why we shouldn't discuss it.
Can I just say though, Chair, not to correct you, but actually it had already been raised for quality and maternity safety.
Yeah.
So we were aware, no, it's important to understand that background. And CQC came in then almost immediately because we'd started talking about those concerns which triggered the visit. So some of our safety kind of alerts had started going. But
Well,
yes.
I know process is going to be important, but actually it's what you hear.
It is,
What you see,
yeah.
and check outcome measures, those are the things that, and also actually some of the staff things, because often problems will appear in staff metrics before they appear in the service.
I think
So there's all, I mean, I know I'm sort of teaching people to such A to B here, but actually I think it's, given the experience here, it's worth it. It's really good to have some of those discussions.
I think at public board Chair, it is also worth, really important to just recognise if there are families that still we've not heard their voice.
No.
The offer of stepping forward is still there, and we haven't always got this right.
And of course, one of the real advantages of children is you've got parents there who aren't sick, who desperately care for their children. Okay, I mean, I think if that actually is quite attacking, that's great, but it seems that that'd be useful to think about in the wider context, not just in this, because we started to do things, one of the lessons we learned. Okay, thank you for that, and thank you for all the work on that. It's good to read the report and see that actually it's quite a positive report in terms of the progress we've made. Thanks for that. Okay, can we move on to Paula? Inclusive place to work.
Thank you. So in April, the board had a conversation around our approach to racism, and subsequent to that, we had a board development session where we spent some time thinking about this. And then locally within both organisations through HMT and SLT, we've been engaging with staff in terms of our approach. So bringing this plan back today for the board's support and approval, please. So just remember we talked about the importance of culture a lot this morning in various different contexts. There is a huge body of evidence that we are all aware of in terms of the link between how staff feel, how engaged staff are, and the impact on patient care. And we had Michael Weston who talked to us last October, very impactful presentation, who really explained that to us in great detail. We've also had, and Debbie's talked earlier about our staff survey results, which tell us that a third of our REACH colleagues tell us that they have experienced discrimination, bullying and harassment from their colleagues in the workplace. And we also know that perceptions are important, and the perceptions of our staff of REACH background around progression opportunities, which Amanda touched on earlier, and discrimination are not good within our trust and need to be better. And our REACH colleagues are more likely to be discriminated against than their white colleagues. And although we've seen definitely some improvements over recent years, certainly in the time I've been associated with Kettering, we've seen significant improvement in some of our res metrics, in particular likelihood of being appointed through shortlisting and likelihood of being involved in the full disciplinary process. But we have much, much more work to do, and within the plan you can see that we really need to focus on improving the experience of our staff and those measures. We've also got, just as added context, the National NHS Equality, Diversity and Inclusion Improvement Plan, which landed recently, which gives us 6 high impact actions to focus on, and those are incorporated in our wider plan. So 3 things that we need to do. Firstly, we need to set very clear standards for behaviours that we expect of all colleagues working within our trust and across the group. And we need to be very clear and explain to staff what we have done when we don't reach those standards, so that staff are assured and reassured that we take action when we need to. We need to educate ourselves. I mean, I think Amanda earlier was saying she didn't think education was necessarily the answer. Personally, I think we need to ensure that everybody is educated about this. I think a lot of the racism that we see is not overt, explicit racism. It's subtle, and it perhaps comes from a place of not really understanding our differences and the relative privileges that some people have against the experiences of others. And most importantly, we need to do this work with our colleagues. So the REACH network here at Kettering and the same colleagues over at Northampton are involved in looking at the plan, giving us their thoughts on the plan, and we will work with them going forwards. And this very much needs to be top down, so the board absolutely needs to give their support to this, but also bottom up in terms of working on the ground where we will make a difference on the day-to-day experience of our staff. There are 5 areas to focus in the plan, and there are dates against all of the actions. Some of those dates you will look at and think, my goodness me, that's a long way away. Those dates are the national dates that are in the National NHS Improvement Plan. We will be having a series of dates and challenging ourselves to be much more, to do this work at pace, picking up on some of the comments earlier today, and certainly that was the feedback from the committee. So those areas of focus are executive leadership and accountability. So for example, everybody around this table, all execs across both organisations need to have an EDI objective. And I will be contacting everybody in the next month or so to ask them to confirm that they have got that objective and they've agreed it and discussed it with does their annual appraisal. We need to look at our HR processes and capabilities. There's a particular piece, I think, in terms of education within my team, and certainly the workshop that we had the other week I referred to definitely brought some of that out, and I was really pleased that people felt brave and able to talk quite openly about some of their learning going through this. We need to improve cultural competence, and in particular I'm really interested to make sure that we support the learning of our middle managers. Those managers who are out on the wards who really make the big difference between on someone's experience in the workplace. How do we educate those managers so that when they're making decisions every day around things that impact people, that they're making those decisions from an educated and informed viewpoint, and they feel more confident as individuals rather than a blanket approach to everybody. That we recruit and develop talent. We have a massive number of people here now, and 5, who've come in through international recruitment or other means, and those need to be our future colleagues at band 6, 7 and beyond. So what are we doing to ensure that they are in the best possible place, and Jane mentioned levelling up earlier, to achieve promotion into those roles? How do we manage talent through the organisation? And we need to support our REIT staff. So we've got things in place for our staff, in particular our networks. So we need to really make sure we get behind the network and ensure that those thrive and can really support staff out on the ground, as well as providing really vital support to us in terms of thinking about how we go about positioning ourselves, how we lead, how we devise policies, etc. Clearly there'll be a bit of governance around this, and the paper talks about hospital working groups. So within Kathleen there will be a working group to think about how you want to implement this work locally, and then we'll bring it together at a group level so that we can compare successes and learning between ourselves. So I'm asking the board today to confirm the support and commitment to improving inclusion by tackling racism and giving their approval to this plan.
Yeah, thanks, Paula. So on the education, a couple of points on the educational piece. I'm actually reading a book at the moment. My reverse mentor asked me to read, which is why I've stopped talking to white people about race. I don't know if anybody else has read that, but if not, I suggest you do, because it's been a really interesting read. I'm only halfway through in terms of things I've never even thought about before. So that's just a helpful thing for people on education. And what I don't see in here is your point earlier, really, Lise, which is about our role as an anchor institution in this, and how we can actively, not just make sure that the strategy includes it, but how we can actively work in the communities that our staff live in, and what we can do around helping to support improvements in housing and improvements in those local environments that will then help that.
I mean, there's a very obvious bit, isn't there, in terms of how we make sure that we are recruiting from some of the more deprived areas and enabling people through, whether it's starting through volunteering or through other support to work programs, to actually get employment, because that is a key determinant of health, isn't it? We've got a good role. So yeah, we can have a big role there.
And I say, I think the other bit of that is giving people confidence that they can apply for these jobs. If you talk to people out there, that's a really big issue. A lot of people, some people don't have confidence that they're going to, we heard from them, they don't have confidence that they're going to be given a fair shot, etc. So that's the other side of it.
And particularly, sorry, just to follow up on that, particularly when we are putting in services in communities, like the CDCs or other things, that's a real opportunity for us to try and recruit from those communities to work in those places.
So I can't, lost my hands with that, so I'm lucky first and then I'll go around.
Yeah, I also to make a couple of points. So, well, I think it's really helpful that it seems to be a real clarity of focus that this responsibility has got to be distributed across all levels. And I think that came through really strongly when Amanda was talking this morning. That we all have to take collective responsibility for that, and that we are really committed to doing that. And I think what that makes me think about is, the piece about reflecting on HR processes and capability. So, one way is, as James talked about, thinking about how to help people be better at applying for posts. The other side of that is, how are we asking people to apply for these posts? Do we need to look at that? And I think the other thing I wanted to just reflect on was, I think Amanda spoke really clearly this morning about seeing people holistically. And there's one or two kind of fleeting references in here about intersectionality. And I wondered if we could just say a bit more about how I'm very strong focus on racism here, and I think that's appropriate for local context, but how does this sit with that broader piece of the cumulative disadvantages that people may be experiencing? Yeah. So the particular focus on race at Kettering was something because it has come up through our staff survey so loud and clear, and in fact in our recent people polls there's further data which I'm not bringing that to board next time, but yes. But we know that we have all sorts of people who work in our organisation who have all sorts of protected characteristics, and nobody is one thing, are they? Everybody is a comes with very their individual situation. We need to focus on race because it's a specific
issue, but not at the exclusion of all other things. And you're right, you know, Amanda's case around managing race and disability. Most people will gender, you know, we've all got gender, haven't we? In particular in the NHS, you know, we're predominantly a female environment, so actually some of our male colleagues really find it difficult to find their way sometimes. So you're absolutely right. The wider EDI inclusion plan that we have obviously encompasses all characteristics. And I'm really pleased to say that we have just this week appointed a senior EDI lead across the group, whose focus will be very much on inclusion in a broader sense, rather than just focusing on race.
Let's go around yours next. George, if you have your, sorry, Alice, for yours next.
That's right, very briefly. The cultural ambassadors, Paula, it's not clear to me quite what their role is in this, so that's maybe something not necessarily for today, but it would be worth looking at. The other question I had written down when I looked at the pack before Amanda spoke, are we confident that awareness and education is the issue? Because our response here is quite focused towards that training course piece. I'm conscious that that sort of got reinforced a little bit by what Amanda said in my head. Not disputing the need for tone at the top amongst us. I worry that we're focusing a little bit too much on us first and trickle down, and we all agree that our trickle down is sometimes what doesn't work. And therefore I wonder if we could be a bit more radical about how we prioritise, not to be complacent as a board, but to say this is not the issue right now.
And that very point was made at a REACH meeting that I was at recently, where the suggestion from colleagues was to the board, they continue to do that, but actually identify a department and then start with the department, please, and start with the people on the ground. So, yes.
I really disagree with what you said. You said that subconscious trickle down doesn't work. Actually, you could remove the subconscious.
Yeah.
John.
Yeah, so I mean, I think this is really nice to put together. It's nice and easy to follow, and I definitely support it. The bits I picked up on was the odd bit that you said about focusing on the middle management, because that's fit to what Amanda was saying. So they're the people who were in contact with the people on the shop floor all the time. So I think that's really important. And the other bit is I think I agree with you that the education piece for me is the unconscious bias. I don't know, but I suspect people aren't deliberately going out of the way. There will be some people, but I think quite often this is people just don't realise what they're doing, and that's probably unconscious bias. So that bit of the education is really important for me.
So can we just go a few points and you can take away?
Just one final point for me. This it can't be top down or bottom up. It's got to be all of those things. It's got to be a multi-pronged attack, essentially, for me.
You have your hand up.
Please, yeah, I was just got 3 points. One is there's quite a bit of evidence that I think Derbyshire has done a quite a significant improvement campaign by investing their local area, and that seemed to be going directly rather than online or by job centres, and that's attracted quite a good applications from those private areas that wouldn't normally access those type of things. I think that's either Derbyshire or Sheffield. I remember forwarding to Andrew there look at that for various things. Second one, just to reiterate Alice's and John's point, I think the point around the middle management and lab structure, it isn't good enough. It's got education and training in there, but hearing what Amanda said, that's just it doesn't feel enough of what the tackling from my perspective in there. And the third one, just looking at, it sounds like REACH have already been, the REACH community be involved in this. It's their input into what the actions are and whether their view of it.
2 questions. Do we have a policy around target setting by grade or by role? Secondly, do we seek to have a zero tolerance approach to racism?
When you say targets by grade or role, do you mean representation in?
Yes.
Yes. No, we don't have a policy on that. We previously talked about zero tolerance. Zero tolerance it's quite a difficult phraseology, isn't it? And I think it's very difficult for people to understand because nuance in these cases, there's always nuance and there's always the need to look very carefully at the individual circumstance of their case. So whilst my personal view is that zero tolerance is a good strapline, because it's a very clear statement, you know, we're not having this. When it comes down to looking at an individual case that includes racism as an element to it, you can't be that black and white. You have to look at the nuance of the individual case. So I think as a board, we need to say, we do not want racism in our organisation, we will not tolerate it. But I would steer away from labels like that personally.
So you don't advocate using the phrase zero tolerance?
I wouldn't.
Just to pick up those, because I think there's a number of points, really good points going on. First of all, I absolutely accept the point this has to be across the organisation, but the board have to set the tone. And that means we have to follow it. Secondly, I know there's a lot of drivers in the paper about not making this. Actually, there's only one in my mind. This is a moral responsibility. We don't have to wait for it to be told nationally, etc. So we need to do that. And thirdly, we need to be calling it out and giving officials calling it out. I have two nets who are from an ethnic background. I've talked because of the subconscious business, which is a good example. They've got explicit permission from the board to call it out. And I think most of us, including me, have been called out. We do say things like everything else, and actually, I'm not going to say it's racist, but so those sort of things. I think the second bit, so I think we have to set that tone and expectations like that. Secondly, I think we need to show examples. I think we do need to consider that we're not a very diverse board and how we do that. And there are things that we can do to help support people in terms of becoming a non-exec. Some places have associates that way. What's our recruitment when we look at non-execs, etc. So I think we need to be setting examples. The third point I think that came through from me is, let me summarise this as it's a glove with an iron fist in. And people I felt thought the glove was fairly thick and the iron fist was fairly small. There's a balance in there. In other words, if people are racist or behave badly, they need to know there are consequences. And your education is actually important. Actually, it can't just be what I've got to do, it can't just be education. And the final thing I think that I heard is, what you found, it's not just about racism, and it's good to hear you about the other people. And the final thing is we need to think about patients. And I'm not in any way criticising this because it's not staff, that's great. But we did pick that up a little bit before the discussions, and actually we need to have a strategy which looks at inclusivity and outcomes, etc., and how we can address those. And that is an important part of the place, not just this organisation. So I know that's not your role, but I think we, as a board, would like us to do that at some stage.
Chair, we also have, sorry, I got the glance.
You were talking about it, so that's what
we also have a reasonable to high number of datasets completed by our staff, which is describing racism to them from our patients. And that's something that we're also addressing.
So I think having that conversation, there's 4 or 5 sort of things. I know there are other points, but those seem to be. So, you know, it would, I think, be useful for us to bring back this board statement. It acknowledges it and sets out our expectations, etc. To our staff and to each other. Okay.
I could just come back one final point, just to reassure the board that in the past we have dismissed colleagues in this organisation for racist behaviour.
But I think the calling out, giving people permission to call it out is really important at the time that it happens.
And I think it's been really clear that it's not just the affected individuals that we expect to be calling out.
Really good. Okay, so thank you very much for that. I think it's a really good point here. Thank you very much. Move us on then, if I can, to the hospital redevelopment programme.
Yes, absolutely. So this paper is just here for noting and as an update, so notice is required. But yeah, delighted that Kettering Hospital remains on the 40 list that were announced in May. Not all hospitals, some hospitals have been delayed because black panels have been added, but we're still on there, which gives us a timeline of starting the work and finishing, according to the national current timeline, 2025 to 2030. So we continue with our enabling works including the Energy Centre, electrical onto the site and moving displaced clinical and corporate services that are in some of the buildings that we're going to be knocking down. So that work in itself will take us until 2025. And we are now just standing up the rest of the work that's detailed in there on the assessment section around really the transformation that this organisation needs to start and undertake to get us ready to move into the new buildings. And so we're just standing that up, and that's internally, and that's hearts and minds and it's ways of working transformation. It's digital, of course, absolutely paramount, but it's also externally with our partners. There's a lot of work we need to do in terms of making sure only patients that need to be in the hospital are in the hospital, because we simply aren't going to get enough money to build the beds for patients that don't need to be here. So that work, whilst it is ongoing, and you gave an update earlier, Matt, it's absolutely essential that we really start to drive that with the partners. But in the interest of time, I don't need to say anything else.
No, that's how to get that update for information. Just to say, I think it's really important what you said. There is not enough money for even the first cohort to do what they've been asked to do, or what they're asked to do. And it's really important that we keep up the pace and keep up the speed and really the transformation innovation if we go to be the first cohort. Thank you. Group Governance Review and Appointments Committee. Trevor.
That was over quicker than I was expecting.
Sorry, I was trying to catch us all up.
So I'll take the paper as read. There's a number of pointers, and it's unfortunate that we do need to go through the recommendations of the request at the end. So the first one was that Alice be appointed a role of chair of the audit committee. Agreed. But Natalie, there's slight confusion, Natalie, I know. But Natalie takes Lisa's place on the Quality and Safety Committee, although Natalie's already on the Quality and Safety Committee.
Let's do that side.
And that on an interim basis, until we propose another non-executive director, I go back into the audit committee, but clearly not as chair of the audit committee. That's on an interim basis, I emphasise. And that we do need to appoint a new member of the Strategic Development Committee. We need to take stock of where we are on that. One, because the committee is currently a joint committee across both trusts, but the agenda is totally skewed to Kettering. That's not deliberately, that's just the way the agenda has been. So we do need to consider actually what the quorum is on that committee, and who should be an appropriate person. And in terms of the lead for maternity and young people, recognise that Lisa's going, she's still the lead for it, she can't escape that yet. But we need to spend some time over the next month determining who the appropriate person is, or people, I would emphasise, are to take those roles. And that Alice becomes a member of the People Committee, and I'll step back down from that, which seems to be a bit of a revolving door. I'll step back down from the People Committee over the 6 years I've been here. But yes, those are the recommendations.
Can I just add one more? Elective Collaborative Committee common. Hasn't been covered here, and Lisa's the name on that as well.
Yeah, I think partly we have a debate around that. I think there's a wider debate exactly where that committee is going and how it goes. But yes, there is.
Just for the, yeah, so add it to the list to be considered. Yes. Thank you.
I think the other thing is here, the discussion about joint committees. I think whilst there was some opposition to one, I think the general consensus was we should continue some track members. I think my so I think we've just okay.
Yeah, may I just ask that Liz moving away from the maternity service piece is really significant, and some real robust timelines around recruitment in that position is essential, please.
Sorry, I just think the important point there is recognising what the the nature of the expectation as opposed to necessarily what Lisa was doing.
Not sure how you take that.
I'm not sure. It was in terms of the size of the shoes that had to be filled.
Oh, right, okay, that's good. Okay, thank you for that. Remuneration and Appointments Committee terms of reference, any comments? Right, I'll say we approve them. Thank you. We don't have any questions from the public. Lisa, is this your last public board meeting?
It is. It feels a bit strange.
Well, I mean, can I thank you, but I feel that really able to ask Trevor to do that. I've only just met you.
You said you put up with me for longer.
Yeah, well, thank you very much, Lisa. It was actually, because Lisa met in previous lives. I've sat on the other side of Lisa being the chair of ECT, sorry, chief executive of ECT. So I was aware of her overall experience, and what you brought to the table at KGH has been massive. And thank you very much for your diligence. I know certainly in chairing the audit committee, you came in, as a member of the audit committee, given that sort of that focus, which was both direct and came from a clinical perspective, but also a massive plus with your public health background as well, in terms of what you bring to the table, because we can have debates, and many times we've had debates on this table, and all of a sudden you come in from a public health perspective, all of us have said, why didn't we think of that? We've touched on it today, in a number of aspects of what we're doing in terms of inequalities, etc. But thank you for your time at KGH, the public board, and for your time before 30th September to say proper cheerio.
Thank you.
Yes, it's interesting, isn't it? I've never met anybody who's both been chair of the committee and maternity champion. Thank you for that. Okay. Susie O'Neill's about to go on maternity leave, so after the speech for a while, so we'll which is very welcome. And the procession outside is what, 12:30?
It's 12:45.
Oh, we didn't have to rush much.
But it's, we need to be there a little bit beforehand so we don't miss it. But Jane might want to just talk about the ward visit.
Yeah, so thank you everybody for volunteering. So I don't know if you want me to. Really? As you do. So we've got a number of visits going on this afternoon. I think everybody knows where they're going. Everybody's not sure, follow now, but I think everybody knows where they're going. I would ask for